Hi, welcome. Thank you all for joining us today. I am very excited and honored to have Gordon Gillespie on the call with me. Gordon has been 9 months in his new role as Chief Program Officer for the National League for Nursing. So Gordon I've had the pleasure of knowing him for many years. We worked together when he lived in Cincinnati prior to moving to Washington, D.C. to continue his career in healthcare. And it's just such a privilege to be able to reconnect with you today, Gordon.
Thanks. And
So,
it's been great knowing Megan. Megan and I have been buddies for a long time, and we used to have weekly phone calls on our drives into work every single week for several years as part of our partnership between University of Cincinnati and Maple Knoll Communities. It's been kind of an interesting little curve for me because I've been at the University of Cincinnati as full-time faculty, rose up through the ranks and became a tenured full professor, associate dean for a long time, interim dean for 2 years, and led lots of programs, did lots of things, had lots of fun. And I was been there for over 16 years as full-time faculty, and now I'm still an adjunct faculty member. And I decided I want to be a dean or a provost at an academic institution, and was out job searching. And then I had this mentor of mine from back in the day that I met, Dr. Beverly Malone. She's the president and chief executive officer for the National League for Nursing. She's probably she's the only U.S. citizen to ever look and be over, like, say, the Royal College of Nursing, like that entity. And they've always
wow.
been like Brits. So it wasn't just like another European, but they actually went across what they call the pond to the U.S., which was just very different. And her racial demographic profile was very different from what they historically had. So it was like quite a leap of faith. And I believe she said that she was also a deputy undersecretary for Health and Human Services under Bill Clinton. So she's got this phenomenal career. She's been presidents of multiple large professional nursing organizations. And she's like, Gordon, I think you ought to consider this. And kind of my first thought's like, that's not an academia. Yes, it's a private nonprofit. Academia usually is a nonprofit, at least where I would be looking for a job. But to completely leave true academia and what I know, like, that was a major leap of faith. And so I ended up going through the interview process to at least see what it was like. And then I got the job call from her. And it was kind of uncomfortable. She calls me on a Thursday and says, hey, Gordon, I interviewed with the leadership team on a Thursday. And then on a Tuesday, she calls and says, Gordon, want to offer you the job. And I go, well, I haven't actually come in for the on-site interview yet. She's like, Gordon, you're not listening. I'm offering you the job. Like, I know you well enough that I don't need to come in. And I was like, I told my wife once we kind of started this, it'd be a couple months. So, like, I'm like in shock. I need some time to kind of think about this. And so really what it came down to is, like, in my career, I know I could be a great dean or a great provost somewhere. And there's skills that I know I'm good, and there's some skills that I think I can develop more. But Beverly Malone is this international global leader. She's got this phenomenal reputation. Even the International Council of Nurses that functions out of Geneva, they know her by first name. And like lots of people know her. And we were just at the International Council of Nurses annual Congress in Helsinki, Finland in June. And there was just mobs of people hoarding her that know her. And they want her to come to their countries and talk about nursing and the future of nursing. So this is the person that when I joined the American Academy of Nursing, you have to have 2 members of the academy to sponsor you. Beverly Malone was one of my sponsors. When you could only sponsor 2 people a year. So it meant a lot to me that she chose me as one of those 2 people. But it's like she's been this mentor. And now I'm like, if I'm going to really learn leadership at the highest level, it's going to be with Dr. Malone. And so the biggest reason I changed these jobs was to go and work for her and see what I could learn, and to know that no matter where I'm at in my career, there's always something more to be learned. And doing it from a great person like her was one. The scariest part, though, was moving to Washington, D.C. metro area. And my wife was close to retirement, so I ended up moving for the position because it's an on-site job. And my wife stayed in Ohio. And she just retired a month ago on September 2nd. And I just drove there or picked her up there and we drove back. So now I live with my wife again, which is really good. I know some of the leaders I've known in the past, they've lived with their partners apart for a while, but my wife and I, we've been married for 33 years. And the only time we lived apart was in 2025. So it's like really incredible. But that's really my biggest reason is that I'm looking at I want to lead at a global level. And one of the things that when I was leaving College of Nursing, I spoke with the dean there, Alicia Rebar, and I had to give my notice. I did it to her before I sent anything on paper. And part of our conversation really was, as a dean or provost, you can influence a great number of students from your institution. But at the National League for Nursing, you can influence students across the country and across the globe. And so the ability to make an impact, a tsunami impact, is much greater in my current job than it would have ever been as a dean or a provost at a single institution.
That's incredible. You've done so many amazing things. So what do you think is, you've been in the academic world. How, besides making the difference, the things that you've just said, how has it been, dramatically different for you?
Well, even when I was a dean and they would talk about contracts, there's always a house of lawyers, like 13 members or so of the legal council. They reviewed contracts. They would sign them. Sometimes they'll say like, well, this you're allowed to sign, but they reviewed everything. In my role now, we do have a legal counsel, but I'm really the signer for everything, except for a few conditions. And I find that I'm reading lots and lots of agreements, lots and lots of contracts. It's like I feel like I need to go back and get a jurisprudence degree, a JD, just because of it. But in reality, I really don't. They're not that complicated. But there's things that, as a scholar at UC, I was involved with being. I've co-edited a book on community public health nursing with F.A. Davis. I've written or published like over 160 articles in peer-reviewed journals as a primary or contributing author. I've done lots of grants and things like that. But at the National League for Nursing, your job is more now to oversee the practice of others. So we do have a publication arm. So it's one of those now people are providing books to us, and I help oversee directly or indirectly getting those books published for nurse educators or for nurses generally. And I still work on publications, but now it's more about, again, instead of like influencing a specific area, it's really about all of nursing academia. And what my boss has let me know is that it's not just for the US, it really is looking at a global market. So one of the events that when I started within my second week, she's like, Gordon, we got funding for a meeting called an Utstein meeting. And I didn't know what that was. I had to go look it up. It's through Laerdal Foundation, and it has to do with the Utstein Abbey in Upstein Abbey in Norway. I think it's Stavanger, Norway. And that's where the first Utstein meeting was held. And it was really looking at resuscitation guidelines. So for those people that have ever seen like paramedics or nurses in the emergency department, and they're pushing a lot of medications through IVs, they're doing chest compressions, and intubating people, that type of thing. Those guidelines, those standards came out of these Utstein meetings. And so it was an international meeting for the international experts to come to agreement on what practice should be on a global scale. It's not, this is how we do resuscitation, CPR in Ohio or the US. This is how we do it in the Netherlands. This is how we do it in the world. And so this international group came up with these measurements, practices, so they could really come back and say, so you can really look at, are the outcomes better in Cuba versus the United States? Some are better in the United States, but some are actually better in Cuba. But you've got to have common measures, and you've got to have a consensus on what that means. And that's what an Utstein meeting is. So she had funding for an Utstein meeting. The first one focused on nursing. They've all been focused on either veterinary medicine or medicine like for humans in general. But this is the first one now for nursing, and it's focused on nursing education. And she's like, Gordon, I need you to make it happen. So it took me a while to figure out that she didn't want me to create guidelines for CPR, because when I looked at the literature, it's like, as an academic, you go to the literature, you look, and I was like, okay, now I'm getting what this is. And so it was my job to convene a group of experts, nurse educators, and clinicians from health systems that know what nurses need to be when they graduate, bring them all into Helsinki, Finland, 13 countries, 60 experts from around the world, and say, let's talk about the future of nursing. And we talked about topics generally. We talked about artificial intelligence, nurse well-being, the international faculty shortage, competency-based education, and we had one more, planetary health. And so it was my job to we found speakers to do like a 20-minute presentation to kind of set the stage for what it is, because not everybody perceives, say, competency-based education in Japan might be different from Australia, different from the US, or they might not know about it at all. So we had to say, level the playing field, this is what it is, and then have this group of experts start talking about what it should look like, what are the challenges, how we overcome the barriers. And at the end of this 2-day Utstein meeting, we have give or take like 4,000 data points. And now our team, we're analyzing all that to really talk about what nursing education should look like for, say, 2030 or 2035 and beyond.
So what are the things that stood out for you that you heard from that?
The biggest one is like we kind of figured AI was going to be a big one because it's everywhere. You can't escape it. Even if you were back in the 80s, you remember the Terminator. That's my
Oh
vision of
yeah.
AI. When the system comes alive and it starts nuking the planet, like that's my image of AI. So it's probably not the best image for today, but
We're
I
about
don't
the
know.
same age, so I think of that too.
Okay, perfect. And like when I do talks, I always have a picture of the Terminator and then I have a picture of like a robot doing your homework. So it's like very different perspectives. But with that, it was really the need for nurses in nursing school to come out with some business skills. They need to be thinking about developing products for market. They need to be thinking about entrepreneurship skills, which is very different from the typical faculty member who would say nurses need to come out being able to start an IV. They need to come out and be able to make a bed. They need to come out and listen for alarms. Like it's very, very different. And the nice part was the group wasn't focused as much about how you do things as about what. And I always think about the need for accommodations in nursing. If you have a limitation or a disability, say you can't hear alarms, you can still be a great nurse. So you can still be a great nurse. There's ways that you can use technology that you can still be alerted to an alarm. But there's also the fact that not every nurse is going to work in a hospital. And we still commonly prepare nurses to work in hospitals. We don't prepare them to work out in the community setting. And this group of experts, that was one of the things they said, is we need to prepare nurses for all walks of nursing and not just for half of where the market is. We need to be thinking about telehealth, public health, community health, environmental health, people be working in long-term care communities, people that are working in hospice agencies, school health nurses, working in manufacturing plants. I know nurses that work above coal mines and providing clinical care for injuries and for family members of coal miners before they go down the tunnel. We've got great stories about all that. But but so really looking at the continuum of nursing and not just the hospital based, and then thinking about these things that are not typical for the hospital based nurse, such as really learning more about digital literacy and telehealth and business skills. That was pretty shocking, and it was really high up in terms of where it ranked in terms of the data.
Wow, that's incredible. What are some of the things, as you're talking to these younger generations and we talk about their need for AI and what maybe their interests and capabilities are, is there anything else that really surprises you about this next generation of healthcare workers that are coming in?
Well, this goes back to my role as an interim dean for 2 years at the University of Cincinnati. And as I talked with incoming students and their parents, or I talked with first year students, there was a lot of, I want to be what I want to be as a nurse. It used to be a lot of labor and delivery. I want to I want to be around babies all day, or I want to take care of little kids. There's still a fair amount of that, but there's a lot more now that say, oh, I want to be a traveling nurse. I want to see the world, and really nursing is my avenue to do that. And I think that's really nice that they know enough about themselves they want to travel, but they're still committed to being a nurse. But I always tell them that they shouldn't do that right away. You need to develop your essential nursing skills and become proficient, because when you're a traveler, there's challenges, and it really varies between agencies. It varies between your placements. And I've not been a formal traveler, but I've been an agency nurse. And when you kind of come in, you're not part of the team. And in kind of theory, like a nurse, there's still a lot of bullying where you have these negative behaviors between nurses and other professions against nurses. But if you're not an insider, you're more likely to experience those negative behaviors in the workplace, where you're going to be basically what we call dumped on. You're going to get heavier loads because you're making more money. In theory, you might not be making more money, but your company is getting a lot of money for you being there. Sometimes you do get paid more. But because of that, they're going to give you a worse load, and you might be unsafe, and it's not spread out. And so it's dangerous for you. And if something bad happens there because you didn't get the appropriate training to the unit, because you're still a new grad, you're not, what are you going to do when something bad happens? And it just sets them up to lose their nursing license or be sanctioned, which affects their long-term employment and economic gain. So like, you really need to go in, find a home somewhere, wherever there, that's a rural setting or urban setting or somewhere in between. Find a place, find a unit, develop your nursing skills, be there for at least a year. And really, when we think about Pat Benner's novice to expert, she says it takes about 3 years to become an expert of where you're working. So really, it's best be there for 3 years and then start traveling, because now you have a strong foundation of knowledge. You start to develop intuition when you can look at a person and go, that patient just ain't right. I might not know what it is, but something ain't right. And I need to get somebody else in, an advanced practice provider or a physician in to come, or another nurse, come and help me figure out what's going on. But when you're still new, you're just not going to see it. You're not going to feel it. You might find numbers like these numbers don't look right, but you're not going to be thinking from intuition. And you really need that art part of nursing and not just the science. You really need to have that art to be able to say, this ain't right and I need to be safer. And that's the biggest scary part for me, is that nurses are wanting to skip those preliminary years of building the foundation just to go and be able to travel, where travel is their priority and nursing is just a way to be able to travel.
What kind of advice do you give for, incoming nurses besides what you've already said? Is there anything else that you're really telling some of these new kids?
So not as much at UC, because there you graduate with your bachelor's degree. But when I talk with nurses or nursing students from other schools, or when I interact with them through a professional association, like say the Men in Nursing Group, the American Association for Men in Nursing, that type of thing, wherever you start, don't stop. And so if you start out as an LPN or LVN, or if you start out as an associate degree, go back to get your bachelor's degree at minimum. The challenge is that when you do that, you might have a revolving door of LPN, LVN staff nurses, but in the end, getting that bachelor's degree really does help. I personally started with an associate degree. It took me 6 years to get it. It took me 5 more years to get the completion to get the BSN. But I realized when I practiced in the ED or emergency department with an associate degree, the motto really was and still is, treat them and street them. The goal is not to bond with the individual. The goal is to get in as many people in and get them out as fast as you can. It doesn't matter where they're going, but they need to be streeted. And if you have a person that's experiencing homelessness, you're going to street them anyway. You don't know what's going to happen to them. You don't know if they're going to make it on the street, but that's not your problem. Your problem is to treat them and street them. When I got my bachelor's degree, I really got a strong public community health perspective. And you also develop leadership skills and other things. That's the RN completion or the BSN completion. And with that, I really started looking at persons experiencing homelessness differently. First of all, homelessness is not a housing issue. Lots of people think if you give them a house, it's going to take care of the problem. It really doesn't take care of why they're homeless. It may be homelessness, but you've got to help them with their economic ability to maintain a job, or their mental health issues. Some people, they've had substance abuse issues. There's other underlying factors that led to the homelessness or led to the divorce and separation and economic collapse that then led to homelessness. We've got to look at all those factors as well. But most importantly, as a nurse, I saw the individuals like, we're going to discharge you. Where are you going to go now? It's like, well, I don't have anywhere to go. I'm probably going to go sit in your lobby for 5 hours until they kick me out in the morning. Or I'm going to go back to the street, and I might end up freezing or having violent issues. And when you're sending a person out and you might give them prescription for $100 eardrops, well, they can't afford $100 eardrops. And you can speak with physicians, say, can they get the economical $33 eardrops? Nope, those aren't best practice. I said, well, here's the deal. They either take nothing or they take the cheaper $30 eardrops that may only be 70% effective. It's either 0 or 70. And they're like, well, this other one is 98, but they're never going to do that one. So we can treat them and street them with nothing, which is what your goal is. And as an advanced practice provider physician, you're looking at best practice guidelines, but you have to look at the reality of them actually getting that prescription filled and taking it. And if it's 0, what's a better alternative? And so those are things that when I became bachelor's degree, you look at the person more holistically and their ability to do things. And I would also be more likely to say, let's get them connected to a social worker. If I think about the older adult community, the older adult community also experiences economic issues or homelessness issues, and if the same thing with the prescriptions, you might have Medicare, but if you don't have the writer to afford the right prescriptions, you're not going to be able to get them filled, or you have a lot of other bills. You got to decide between eating protein this week and getting a prescription filled. You still got to have some protein. You're going to start having muscle mass reduction that's going to cause you other problems and health issues. So as you start exploring the individual from that level, you start to engage differently. Get them into social work. I could call up my friend Megan at Maplewood Community and say, hey, I've got this situation. Can the foundation side, could they do something to help this individual get through this 1 month acute period? Maybe pay for their medicines, and then they can go back to paying everything else normal, and they don't go into a spiral. But those are things that you get your bachelor's degree. tell them then also keep going. If you've got the opportunity or the affordability, or you've got somebody to help pay for your schooling, get your master's or your doctoral degree. I personally got my first doctoral degree was a doctor of philosophy, a PhD. I continued working at the bedside in the emergency department for 4 more years. Most people did not know that they would look at me and be like, wow, you seem pretty smart. You probably have a bachelor's degree, don't you? And I would go, yes, I have a bachelor's degree. Because that was the question they
Yeah.
asked. In reality, I had a
Yeah.
doctoral degree and I had a master's degree. But working with those advanced degrees at the bedside, all it did was really contribute to better patient outcomes and a better patient experience and a better experience for my coworkers. So it doesn't mean you have to leave the bedside or whatever environment you're working in, but you could definitely use those skills as you go along to continue going to contribute to better patient care for all.
That's wonderful. We So what are you thinking about? I know we talked a lot about what future students may be experiencing and what you see about nursing as a whole. What kind of insights do you have on maybe how that's going to impact geriatrics in the future?
I think one of the challenges is most of the world knows that the geriatric population or older adult population is growing. I don't think nobody disagrees with that, but I don't know so much that nursing has really thought about that. When they do practicums, we have focus areas for peds, we have focus areas for mom baby kind of wellness, like neonatal, maternal, we have that, and then we have psych mental health. And some places still have population focused care, which is what I kind of call community public health. But a lot of schools are getting rid of the community public health, which is where half the nursing positions are, which is unfortunate. And they're building more time in acute care and building more time in the hospital for those kind of clinicals. And again, the only thing they really carve out is mental health, which some places I've learned are now carving and getting rid of mental health. So really the only specialty you're looking at is pediatrics and maternal. And it's one of those, yes, older adults will be at the hospital, so we'll kind of do that, but you're not really teaching about older adults as a call-out population. And the challenge is older adults are living to be a lot older than they used to be. We have a lot more centenarians or septenarians. Like as you get 70s and the hundreds, those numbers are growing and growing. We're back in the day, so to speak, people that lived to be 60, 70, it was like phenomenal. But now we've got people living into these older ages. It's a larger volume, and their issues are very different from the issues of the average adult. And I think a lot of textbooks really teach to what the 40 to 60-year-old person would look like without really calling out. Like they might say, like, here's a little call out box. Older adults may have greater hearing loss because of they're taking these medicines. But you're not really focusing in on it the same way. Where to me, it really should be, do we have a clinical rotation focused on older adult care? The rotation doesn't have to be in the hospital setting. It could be in a long-term care community. It could be in a public health setting. But they need to have experiences where they're dealing with older adults and the older adult aging issues. And they can also learn that not every older adult ages poorly. There's some people, when you do like this, like fitness ages, and they're running rings around me and I'm limping up a stairwell and I'm like, how does the 70-year-old look like they're like doing this marathon and I can't even walk down the street without getting short of breath? So
Same. I'm right there with you.
yeah.
Our residents amaze me every day. Number one, how active they are, their schedules. They're in the gym 6 days a week. I'm like, I need your motivation.
Now, when you see some of them, they're flexing their muscles. It's like, wow, that looks like my thigh, except my thigh is fat and yours is muscle on your arm. It's like it's a little embarrassing. But it's like knowing that what we kind of get in the textbooks might be kind of stereotypical. So they really need to have dedicated experiences in older adult communities. Again, whether it's long-term care, acute care setting, but it needs to be focused where here you're not just going to be taking care of people with bowel problems. You're going to be taking care of people from this generation and then looking and then really having them go to multiple settings to really look at what does older adult population look like, older adult healthcare look like across these different perspectives.
Wonderful. I love that. I'm trying to think, what are some other things that you would want and again, we'll edit out some of my commentary and asking questions, but what are some of the other things that you would want the audience to know as far as the nursing field or how you've come to be in this role or anything that you want to share?
Something I would say is to advocate for nurses. It's crucially important. Nurses do not advocate enough for themselves. So having the population at large, older adult communities and others advocating for patients or advocating for nurses is crucial. And some things they can do is one of those, they can always help provide scholarships if they want to donate money for for nursing students that say can't afford it, or like especially in rural settings are hardest hit with the government changes where they're decreasing money for scholarships, or not scholarships, but for student loans. That's really going to hard hit people from lower economic levels, which hit urban areas as well as rural. But rural settings, you're more likely to have people starting with an associate degree or an LP and LV program. Those students are a greater need for financial support than, say, an urban setting, where they might have a lot of institutional wealth from billion-dollar endowments. So really looking at where they can give to support. But it's also, if you're ever a patient and you have a nursing student come in, sometimes they'll say, do you want a nursing student today? Or they might say, you don't want a nursing student, do you? Say, I would love to have a nursing student. And there's two parts of that. One is that you're helping to educate and train the next generation. Yes, they're doing things to you or with you, but think about this also, is now you have two sets of eyes. The nursing student isn't going to be your only nurse. If you have a nursing student, you still have a primary nurse who's responsible for you legally and ethically. The nursing student is just an additional set of hands, additional set of eyes. It's kind of like when you're going for a family vacation, you can have a butler with you, or you can go on your own. Not that nurse's role is to be a butler, but it's like one of those, if you could have an extra person with you to do stuff for you for free, why wouldn't you want that? Yes, they're new and they're going to kind of fumble with some things, but it's one of those, if you're uncomfortable, say, I would love for you to give me that injection, but I want your nursing faculty here, or I want the staff nurse here watching you as you do it. That's definitely your right, and that should be the expectation. As opposed to being like, I know you're about to graduate, you've got a lot of independence, but I have a level of comfort. I don't know you, so I still want them with you as you're doing this, just for my own personal safety. That's your right. But it's best to not say no, because they need to be educated somehow. And if we only have, they don't get exposed to as many types of people, demographics, illnesses, medicines, and such, that limits their ability to provide safer care later. Because we want them to be able to have true good experiences. Other things are knowing that there's going to be times when you're going to be horribly angry about something in your healthcare. You're going to be angry. You might even use the word pissed off. You might want to yell, cuss, scream. I've dealt with lots of individuals in that area, but be mindful that when you express your needs once and what you're experiencing that way, you cause other people stress. Just imagine you as an adult or older adult, if somebody's screaming and yelling at you, are you smiling, or are you starting to get anxious and you want to retaliate? You get angry yourself, you're getting frustrated, stressed. The nurse is experiencing the same thing. Do you want that person now to come in with medicine for you and hope that they administer it safely to the right person, the right dose, the right route? There's some risk involved, and it may not be you. It might be they're risking now patient safety to another person. And I've had an experience where I had a nurse when I was working in the emergency department who came to me and asked me to help calculate a dose for a child. The syringe of medicine was Tylenol, not a high risk drug for infants because they get it a lot, but still there's risk if you give too much to the liver. And she was asking me how much to give. The syringe contains 80 milligrams of infant dose Tylenol, and the prescription was to give 80 milligrams. So basically give the whole thing. It's like saying, if I'm supposed to give a pill, how much of the pill do I give? Well, you give one. She was having trouble focusing because of something that just happened. That is problematic. And that tells me that when nurses are stressed and they're receiving bullying and aggression, whether it's from patients or coworkers, it puts other patients at risk. And so for that, we talked about what she needed to do. And afterwards, we had a debrief like what you need to do. You need to step away from the unit. You're really not practicing safely to ask that kind of question. And it's just like this, people that might take furosemide, like a water diuretic. I need to take one pill a day, and they're asking how many of those you should get. You'd be like, wait, what's going on with them? So it's also one of those, try to express yourself differently. If you're getting angry, mad, it's best to say, be like, Megan, right now, I'm really getting angry and I'm having trouble controlling my emotions right now. The best thing for us is for you to leave the room right now. Let me get my composure back, and maybe have the charge nurse come back in instead, because I don't think right now you and I are going to work well. That's better than screaming, throwing, cussing. It's going to upset the person, yes, but it's a much lower level, and it still gets your needs met that way. It makes it very clear they can't stay there, they need to go. And it's the same if you hear somebody else yelling in another room, calling out and getting a manager and say, just want to let y'all know that I heard a lot of yelling in the next room. I don't know if you know about it, but you might want to check on that nurse and the patient, because they probably both need some support. So really advocating that way as well would be really good.
These are all great, suggestions and things that I think people would really benefit from hearing. Not just people in senior living, but see people in healthcare, people interested in a career in healthcare, or even just, having families hear some of the suggestions and thoughts about what you see the future of healthcare and, geriatrics and everything being has been really incredible. I really appreciate you sharing this. Are there other things that you would like to share today?
I would just say something always, anytime you're in a healthcare setting, thank the nurse for being a nurse. Nowadays, during COVID, they were kind of listed as heroes for a while. And the oddly part, that was like the 200th anniversary of kind of when Florence Nightingale was born, and she kind of was the founder of modern nursing. But it's one of those, since then, nursing is not at the same limelight and it becomes very thankless. Nurses are experiencing high rates of burnout, depression, suicidal thoughts. They're not, nurses are leaving the profession at almost a faster rate than they're coming in. And right now we need 200,000 new graduates every year just to meet the number of nurses that are leaving. That's not even to, as we get more older adults that require more healthcare services and more nurses, we're not meeting the demand. So really get to a nurse and say, thank you for being a nurse. And even if it's like, I know you and I really didn't get along really well today. We had some challenges, personality or whatever. I know I kind of accused you of whatever. But aside from all that, thank you for being a nurse. I hope that, your experiences as a nurse will be better, but thank you for being a nurse because it takes a lot of schooling. It takes a lot of time. And it takes a lot from families with the shifts that nurses work. They work 24-hour shifts, not individually, but nurses, they work a lot of night shifts. They work weekends, a lot of jobs that they don't require that, the office kind of 9 to 5 jobs. So just thank a nurse, say thank you for being you. Thank you for making the commitment. It really does a lot, just as little moments of compassion go a long way to improving that person's day and helping them to be more effective for the remainder of their shift.